Howard.
The next section is AIDS. It was identified in 1981. The problem with it is that the virus takes over. True or false, HIV is the same thing as AIDS. How is that different?
AIDS is not treatable. AIDS is not curable.
HIV is the virus that causes AIDS.
Correct.
Yeah.
So you can have HIV and have the virus in your bloodstream, and it may not ever develop into AIDS. AIDS is that the virus is taken over, and you have AIDS. You don't get rid of AIDS, right? You might have HIV. It's the virus that causes AIDS, but differentiate that for your patients. It's the same thing. No, it's not. It's different. You have people all the time that aren't in the medical world that say stuff sometimes, and I'm like, oh, no, it's not. I try really hard not to correct people if I can help it, but don't tell anybody to say next to an airplane that you're a nurse, because sometimes you get medical stories. I can attest to that. Oh, you're a nurse? Well, I'm a diabetic. Oh, here we go. My blood sugar today was 425. Really? Yesterday it was 12. Okay, that's it. You care if I turn this air thing off? I'm like, no, I don't care. Turn it off. It's fine. Well, my sister had that on the whole time. Now she's deaf. She got deaf because that thing was on the whole time. All I could do was just like, okay, I guess I'm not going to listen to my book on this flight because I'm still listening to her medical stories. And I did not correct anything that she said. Anyhow, I digress. The virus enters in, takes over, reproduces, takes over the whole factory, and is dysfunctional for your patient. All those other helper cells, all that stuff becomes weak, and the patient develops indications of AIDS, the immune system versus the virus. That's the problem, the issue. Spread through sharing bodily fluids, not spread through kissing, things like that. Can be spread from mom to baby, get stuck with a needle, not transmitted through casual contacts. So as we expect that white count, you expect that to be low. You expect the A and C count to be low. Because the virus is taking over, right? And your normal immune cells are getting overcrowded, getting taken over. Positive for HIV doesn't mean that you have AIDS, as we just talked about. That means you have the virus present. It doesn't mean that it's taken over your whole system. A and C count, as we said, that's a biggie to know for patients. That's their ability to fight off an infection. Again, you don't have to differentiate between mild, moderate, and severe. Just recognize numbers and think to yourself, okay, how significant is that or not? So, the syllable penia means lower number of, P-E-N-I-A. If you type it in and have a different letter at the end, you're now in reproductive class. That's why I get spam on my computer. Penia means lower number of. Neutro means white blood cell count. Again, when you take your NCLEX, don't freak out. You run across a word and you're like, I cannot remember at all what neutropenia means. Neutro means white blood cells. Penia means decreased number of. Voila, I know exactly what's going on with this patient. So we'll keep track of that number for sure for this patient. Viral load is a term we use to see how much virus is still floating around in his bloodstream or in his system. That's something that we test, we check. How effective are our medications? How has it done for your viral load? How much virus is still hanging out in your system? Our goal with your medication therapy is for you to get into what we call undetectable. If the medication is effective, we shouldn't be able to detect any more virus in your bloodstream. Undetectable load. And in theory and in patient teaching, if we have an undetectable load, undetectable level, that means I don't see any more virus in your bloodstream, and you cannot transmit your virus to someone else. Because if it's not present in your bloodstream, it's undetectable. It means you can't transmit it through sexual intercourse or the the ways that normally the virus would get transmitted. That's our goal with medication therapy, is to get to be undetectable viral load. And for those of you who watch TV, you'll see that on commercials, so advertise medications, and it said to get you to undetectable viral loads. That's what that means. Ideally, ART means antiretroviral therapy. That's the name of the group of meds. If you see that category, antiretroviral therapy, anti is against, retroviral is against the virus. That's the broad umbrella term. The problem with that, though, is sometimes it's got side effects. Sometimes it's a lot of pills in a day. Sometimes it's expensive. So to get people to take all of their meds for their HIV or their AIDS sometimes is not that realistic. So yes, if you took all your meds exactly as prescribed, and your body responded exactly how we want it, we could exactly get you undetectable viral load, and you would have your virus managed. All those things have to come into play though. So you have patients that are compliant, don't take medications for whatever reasons, and I forget, they're too expensive, I need to get filled, on and on. Again, knowledge doesn't equate to compliance. What can I do to help you out so the medication taking is easier for you? Do you have them set out with your cup of coffee? Do you have them set out with your toothbrush? What kind of program do you have that pays for those medications? Or there's something else you might be eligible for so we can get them to be less expensive for you, because you might be able to be covered by some programs. So what can you do as a nurse to sit down with you to help you be more compliant? Well, I don't like this one in particular. Well, can we talk about maybe there's something else that we can substitute for that? Or maybe we can wean you off that. Maybe we can take you off of something, come back in another month, we'll check your viral load again, and we'll see what we can do to perhaps adjust your stuff, your medications. So there's lots of things for us to say, well, you just have to take all 10 of them, like it or not. Well, not really. There's probably stuff that we can do to be creative as nurses to help them out. The situation, the problem is that a patient may be infected with HIV, their virus replication is occurring, they don't know it, their immune system hasn't kicked in yet, and they can transmit it to someone else in the meanwhile. That's the problem. So probably the take home for this one is, what does it mean to have this as you see that documented in a chart? What does that mean? Do you understand that as the nurse, what that means for your patient? Common complications associated with persons with HIV is it affects the respiratory system frequently. It affects a combination of other cells. I'm not spending much time on it, neither do you. Respiratory system, you studied TB when you studied respiratory a couple weeks ago. Lots of body systems, a lot of things going on there. HIV wasting syndrome, that means they've had an involuntary loss of greater than 10% of their own body weight associated with other GI stuff. That's preceding that. Kaposi sarcoma is a malignancy that we may see related to HIV. And then lots of body systems. You'll get to neuro in a few weeks. Talk about some of those things. You don't need to know these medications. You don't need to know specific medications. I shouldn't say you don't need to know these ones. You don't need to know specific ones of these. However, be familiar with the whole broad category of antiretroviral therapy. Break that word down if you can figure out what that is. They inhibit viral replication. They don't kill the virus. They just keep it from replicating on itself. Oftentimes multiple meds, we talked about. There's lots of actions these meds do. You don't need to know all of these unless you're working in a research lab or you're working in some pharmacy specialty point you need it out. However, what I should have put in red and bold is at the bottom of the screen. This category of meds is very toxic on the liver and the renal system. The antiretroviral category of meds is very toxic hard stresses on the liver and renal system. Those are the labs that you want to watch out for. I see that you're taking Retrovir for your HIV, and I'm going to have you make sure you come in for routine liver function tests and routine renal tests. Knowing that what goes with that medication is sometimes it causes problems in those two organs. So your patient is being treated with, given one of these meds, could you recognize the name of the med that falls in that category? And what kind of monitoring are we going to do with this patient? Sign them up for routine liver function tests and routine renal function tests. So recognize the names of those. Those are pretty cool. Retrovir, it's got the virus in the end of it. Zovirax, like I said, I wish they all were that way. Again, red and bold should have been red. Check the renal function, check the liver function. If you're stressing those organs out, we probably have to have a conversation about what we're going to do about your medication. We can do other medications that will cause immunosuppression. The fine balance on, we got to keep this virus under control. We don't want to stress out your vital organs. How do we make all that happen? This is a scale that we sometimes will use with patients that have a change in level of consciousness, ABPU. You may see that in the ER. You may see that in the recovery room settings. It's pretty straightforward. They're either A, awake, they respond to verbal, painful, or unresponsive. Some of you might be at B level today. I don't know. So these medications, the side effect may be confusion, so keep an eye on that. Your patient comes in with confusion, just do some lab work. Because confusion is caused by lots of stuff, right? Urinary tract infections, and so sometimes we make assumptions for confusion, and it may be just an electrolyte issue. So I would not hesitate when you're practicing as a nurse and you're working in a setting. Don't make assumptions that the confusion is caused by, can we just run some lab work just to be sure that there isn't any levels that are off, like sodium levels, stuff like that. Because sometimes these patients get into those situations and they're easily fixable. My mom had a surgery, got confused after the surgery, and then they attributed it to her taking pain medications, right, because she was older. So it's probably related to that. So here we go. So quit giving her oxycodone and give her something else. Is it still confused? Probably this, probably that. We go like 4 days of this probably stuff. Why is she getting confused? I called it. And then, my parents are from the generation where you don't question the healthcare providers because that's the way when you're older like that, older than me, older. So I call the healthcare provider and I'm like, Mom is still confused. We've done all those things and she's still getting more confused just since she came home from, and her sodium was 124 or something. It's like, no wonder she's confused. And it could have been like, if you done lab work 4 days ago, we could have been having that figured out instead of getting sick right now. So that's my recommendation. If you ever have thoughts about that, just run some and see what's going on. Okay, questions about that part? As you know, I cruised through it pretty rapidly. The important part was the medication piece of that, undetectable viral load, what you need to monitor for when a patient's taking antiretrovirals, what medications fall into that umbrella group of meds. Questions about that? You guys ready to keep moving on? Okay, we're going to get into rheumatic diseases now. They formerly were called connective tissue disorders. It doesn't matter. The problem is it's autoimmune. Once you have them, they don't go away. They're systemic. Just because they don't go away doesn't mean you can't keep them under control and you may live to be a long time. They are autoimmune. The body doesn't recognize self. It attacks itself. Women more than men on a 2-to-1 ratio for this category of diseases. Sorry, girls. The pathophysiology of these diseases is the antigen presents to the T cell. Antigen is the troublemaker. The T and B cells respond, cause an increase in synovial fluid. Synovial fluid is that fluid between your joints that make you mobile. And the result is pain, stiffness, and swelling in the joints because of the antigen response. The neutrophils build up, the cells increase, again causing a collection of fluid, therefore a decreased motion in there, swelling, and that's how it evolves. The synovial fluid that's building up in that joint gets inflamed, your cartilage starts to degrade, and there's where the problems continue. The bone starts to erode, the ligaments become lax, problematic cells invade the cartilage and producing you have a patient that has decreased mobility in their joints. I would make this on your little cover sheet of labs to know for no matter what rheumatic disease we're talking about. So increase in creatinine may indicate renal problems. So if you're given a rheumatic disease of any type, the question could be, what kind of lab findings do you expect to, what kind of lab values do you expect to see? So perhaps an increase in creatinine. That's why we want you to know the normals for those things. A decrease in red blood cells, the common theme. ESR, that's one that they'll probably run as soon as you come in as a patient and start to report joint issues, a new onset of decreased mobility. That is, when that is elevated, it indicates, generally speaking, an inflammation process going on. So ESR is a number that we keep track of. It's going to be one you're going to want to put a star beside for your own sake of knowing. Elevated ESR means inflammation. It doesn't tell us what you have specifically going on. So that will tell us that you've got some inflammatory process. The higher the number, the greater inflammation. And now we're going to need to drill down about what perhaps disorder specifically that you have. Hematocrit, typical decrease, typically decrease of white blood cells. I don't worry about VDRL as much. Uric acid goes with gout. And we'll talk about that disorder later on. ANA is another big one that we will run that test. Yours is negative. A positive finding often is correlated with a lot of these disorders. Negative is normal. Positive is not. Anti-DNA, anti means against. So yours should be negative. You should not have anything fighting your DNA. Positive anti-DNA is not good. So negative means that it was not present. That's what yours should be if you don't have some other disorder that we're talking about. Positive means that it's present. Sometimes that verbiage, I don't know about you, but it's mixed up in my head. Or on complement levels, we see decrease of those. Complement is spelled differently than giving you a compliment, like on what you're wearing or whatever. It's COMPLE. Speaking of which, what do you call that number that you're checking when I've got that pulse ox on you? That's called an O2. Stat is not a stat. It's a saturation. So if you're used to saying he had a 96% O2 stat, what did you say when you said stat? That you did it
Right now.
urgently. It's not a stat, it's a stat. Same for your organ. It's called a prostate. It's not called a prostrate. A prostrate is when you're lying on the ground typically, right? That's called a prostate organ. Please don't mix those up. Because you'll probably see me rolling my eyes and go, oh my gosh, seriously. And that's another story. I was in a funeral viewing line with a gentleman once that told me about his prostrate problems. A, we're in a funeral line. B is not called prostrate, honey. I didn't say that, but I had that. Did I tell you about my oh my golly, here we go. Here's the funeral line. How's the weather? How the rest do, you know, I have ankles, whatever. Okay. Low complement levels. C-reactive protein, normal is none. If it's reacting, that's bad. So just kind of in your brain, normal is negative, for several of those ones we talked about. Positive is present, not good. Immunoglobulin, I'm not worried about that one. Rheumatoid factor, look at that. 75% of patients with rheumatoid arthritis have a positive rheumatoid factor. Again, yours should be negative. Negative is normal, positive means present. So we're running all those labs because sometimes when you walk in the door as a patient and say, oh my gosh, I've got stiffness going on in my joints, no matter what I do, it won't go away. I'm having trouble swelling in my fingers, whatever it is. A lot of times we just run this whole panel and we have to start somewhere with you. You gotta figure out what you might have going on. It's frustrating as a patient because sometimes, like, unlike the heart, sometimes we can run a test or two and know exactly what you've got going on. But this, not so much. We just have to play sort of the criteria when it isn't game and keep trying to narrow down specifically what you might have. Antigen, again, you should not have this antigen present. Antigen's a troublemaker. ESR, know that number. Elevated ESR means greater inflammation. Uric acid, we'll talk about that when we get to gout again. Increase with gout. Of course, creatinine, hematocrit, and white blood cell counts. So those normals, just need to kind of keep putting those in your brain, put them on your cover list, put them on your flashcards, find cheesy ways to remember some of those if they aren't able to be remembered very well by you. Meds, these are generally speaking, again, we're not talking about disease-specific ones. Sometimes we'll prescribe aspirin for those patients to take regularly. In red and bold, aspirin, as we know from cardiac, may cause increased signs of bleeding, increased bleeding. So these are never normal, right? Dark tarry stools are not normal. Petechiae is not normal. What is petechiae anyways? Little blood spots right into the skin, right? So report any of those when you're taking your aspirin because that means that you probably have bleeding going on and you check your coagulation levels. NSAIDs, we'll often prescribe those. Those pretty effective sometimes for patients' mobility, for their pain. Sometimes they'll take those around the clock. Do you recognize those as a nurse? What meds fall into the NSAID category? So I probably won't tell you your patient's taking an NSAID. I'll probably tell you he's taking ibuprofen or something else. So could you recognize those if you were given one specific name of one of those? Increased risk of cardiovascular events with NSAID use. So your patient has a history of stroke, your patient has a history of an MI, NSAID routine use for his disease is not going to be a good choice for him. Because he's already at risk. You're going to increase his risk by giving an NSAID every 4 hours. So when you're given a history, when you're looking at your patient's charts, when you're giving patient care, when you're looking at your patient's charts next week, when you're looking at your patient's chart when you're taking your NCLEX in May, is there anything in his history that's going to make me be concerned about him taking his ibuprofen every 4 hours? We only give you history on our test if it has something to do with something. So if we tell you this is his history, see if there's anything in there that red flags for you to say, oh, I should tell him he cannot take ibuprofen every 4 hours for his disorder. In red and bold, when they're taking a DMARD, disease-modifying anti-rheumatic drug, rheumatic diseases are what we're talking about, a DMARD could potentially cause retinal damage. So, in addition to routine liver function tests, In addition to routine renal function tests, because you're taking a DMARD, I need you to also every 6 months come in for an eye exam. Knowing that that category of meds could potentially cause retinal problems. So you're educating your patient who's taking a DMARD. You're gonna tell him to come in for what routine exams? Could you pick them off the list if you needed to? Eyes, for sure, liver, renal. Plaquenil is one of those that fall into that category. This semester, we gave you both generic and brand names. So if you see this medication come up next week, I'll give you both. And $2.75 on your NCLEX, you only get the generic name. So kind of start to get familiar with those. They give that because, again, everybody, you all take the same NCLEX, whether you live here or you live in one of our territories. So we have sometimes brand names around here that they don't have in another part. So the NCLEX always contains just the generic name, not the brand names. So your patient is taking this for one of his disorders. You're going to tell him to take what routine exams might be how that goes. So can you recognize one of these DMARDs? When COVID hit, this was the medication that they thought everybody should take all the time for everything. It had some effectiveness, sometimes it didn't, but that was the med, that was the hot spot for everybody getting rid of their COVID. I don't know if it worked or didn't work, but maybe some of you might have a research lab someday. You can help participate in some of that stuff. Xeljanz is another DMARD. And sometimes we'll hear that advertised. Methotrexate is another DMARD. Can cause birth defects. So I really need to educate about good birth control if you're taking that one. Questions about DMARDs before we go to another category of meds? Corticosteroids, some of you have given those already in the hospital, I'm sure. Pretty popular, pretty effective, can cause elevated blood sugar. So I'm giving a corticosteroid to an inpatient. The inpatient freaks out because you're coming in testing blood sugar every 4 hours. Am I a diabetic? No, you're not a diabetic. But this medication causes elevated blood sugar. We're going to monitor that while you're here. That's the teaching that needs to occur. Lots of side effects. If you told me I was going to look like this when I took this, I probably would not be compliant with taking that medication that you just prescribed. So I understand that this causes you some side effects. And sometimes that's a decision that they just have to decide and make. Just saying, I don't know where that came from. Wouldn't that be great? Sign me up, double dose. We can also do cortisone injections, which I'm sure some of you may have been part of, maybe you have participated in, had somebody that had one done. It's a fix. It doesn't fix the disease, but it may make you more mobile, right? We can do anti-inflammatory processes right there at the joint. Every 3 months is the most that you can have, the most frequency you can have of those. We inject the cortisone right there at the spot. This watch out is put here for a reason. This here is put here for a reason. You as a nurse, you're in the room. Your patient's getting a local injection into his knee. And you're monitoring him because you want to make sure that that medication has stayed in his knee and has not gotten into his bloodstream, right? Because that's not what it's supposed to be doing. It's supposed to stay right there. You're monitoring your patient for these symptoms that may mean that it has gotten into his bloodstream. The anesthetic, the corticosteroid, is supposed to stay in the joint tissue, not go into the bloodstream. So you're the nurse, you're watching out for what indications that it perhaps has gone into his system. And as you can tell, just categorize those. Those are the same things that go along when we give a patient normal anesthesia when he goes into surgery, right? So decrease, decrease, decrease. So decreased respirations, decreased blood pressure, decreased heart rate, decreased speech. So those are all, you can kind of put one little note on there. Absolutely critical that you're the nurse is helping out with that procedure, that you're monitoring for this. Because that means that it's gone systemic and not stay local, which is not the intent. Questions about that? Again, corticosteroid injections can cause some similar side effects as to corticosteroids that are given through a pill.
What do you do for somebody that starts to have those things?
Pardon me?
What do you do for somebody with those symptoms?
You manage the symptoms. Blood pressure's going low, then you give them something to get their blood pressure back up.
Just
Stop the procedure and, yeah, good question. If the face is pale, what kind of bed position do you put them into if they have low blood pressure? Pendellenberg, because you want to get more circulation to their head, right? So face is pale, raise the tail. Face is red, raise the head. Face is blue, you're through. Somebody else added that, I did not. But face is pale, that makes good sense. We want more blood to go to the head, right? We had a student once that worked in the jail after she graduated. A couple years after that, she comes in, she's super funny. I gotta tell you what happened. This inmate went down. He went down. That's what she says. And I said, really? And she goes, yeah, they're just letting him lay there. And he looked super clammy and yucky looking. I said, raise that tail, raise that tail. Oh my gosh. She goes, I thought about you. I said, okay. They took his blood pressure real low and she goes, I kept telling her to raise the tail. Questions about general management of rheumatic diseases before we go into disorder-specific things. Do all of that make sense? So we could be given any kind of patient situation. It could be some funky disease. There's lots of them out there that you've never heard of, but the question will be about the management of that rheumatic disease, as in we're going to give him a DMARD, we're going to give him a corticosteroid, we're going to give him a cortisone injection. So don't get hung up if it's some funky disease. You're like, oh, I don't remember covering that in class. I must have zoned out. The question, what's the question? The question is, oh, I get it. The question is about you're helping out with a local cortisone injection. That's what the question is. Because you're going to run into that also when you take your NCLEX. You're going to see a history. I have no idea what that patient has. Don't sweat it. Just know what you know. And just organize your thoughts and think, what do I know, generally speaking, about this problem? And you'll be fine. Trust me. Okay. There are over 200 some rheumatic diseases. It's probably more now. We're going to cover the ones that are the biggies. And you can spend lots of time. You could work in a clinic at some point in time or work in your nursing career and you'll cover lots more. You have patients that have odd and end ones, but these are the big ones. Rheumatoid arthritis is one. It's a problem in the synovial fluid. So when we go to these disorders, to sort out your notes, where is the inflammation is my question I would give to you to put in your notes and to ask yourself when you're studying. So the inflammation is in the synovial fluid. I can't spell rheumatoid, I can't spell synovial. That's how I know that those two go together. That's where the inflammation is. If you need to know some risk factors, I will tell you that. Because there's always studies, concerns, trends of where risk factors that patient presents with. Problems in the synovial fluid. Again, joint pain, swelling, warmth, just like typical of what we've been talking about for all of these. Starts local, develops some nodules that are not very mobile, causes a lot of pain, decreased mobility. Again, rheumatoid factor is probably the one I would start with. This one specifically, positive over 75% of the time or so. So patient presents with all of these sort of vague symptoms. A positive rheumatoid factor may indicate that that's the diagnosis you're going to give to this patient. Increased ESR means general inflammation. It doesn't tell me what you have specifically. Those are the tests that we're going to run. We can withdraw some synovial fluid from the joint. take a look at that. It should be clear, it shouldn't be yucky and cloudy looking. Again, for all these disorders, you don't need to write these down. We will have to just sort of narrow down and figure out what disorder you have and what one you don't. So a lot of times we have a chart to say, do you have this? Do you have this? Do you have this? Yes, no, yes, no. Well, we think you have rheumatoid arthritis because you've met 5 of these criteria, first of all. You present with typical symptoms and you have a positive rheumatoid factor. And that's kind of how that typically goes. It gets frustrating as a patient. It's like, he thinks I have this, or she thinks, well, that's all we can do. Okay, before we start you on your immunosuppressant meds for your disorder, we need to make sure that we do a TB test because we want to make sure you don't actually have TB right now. Because we're going to suppress your immune system, right? And we don't want you to have a disease that's active and then we're going to shoot your immune system down further. Why are we suppressing his immune system? Correct, so it doesn't attack itself. These are autoimmune disorders, you're exactly right. They attack itself, they're on overdrive. Immunosuppressants are appropriate because we want to stop that attack, that overdrive. Yep. Again, the DMARDs we already talked about might be prescribed for this particular disorder. We already covered those a bit ago. Routine lab work. Lots of meds fall into that category. An immunosuppressant might be prescribed in addition to a DMARD. Stand Immune is a popular one. I like that because it's got immune in the name. Again, we got to be sure we are suppressing your immune system, or we're not going to send it too far. The inflammation is where for this rheumatoid arthritis? Synovial fluid. So we can actually, this is kind of gory if you ask me. We can actually pull off some of that synovial fluid. If it's persistent, we can't get under control with meds, we might actually take you into surgery, open that up,